Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. Today, we are joined by our main speaker, the head of the IMST based in DRC, Dr. Ngashi Ngongo. I will now hand it over to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Yes, thank you very much, Director. Good morning, good afternoon, good evening, colleagues, depending on which part of the world that you are in right now. I would like to welcome all of you to this briefing again on the emergencies, public health emergencies on the continent, on Mpox in particular. This is our last briefing of the year. I think we are happy that you could join us, and we are going just to share some of the good news about the good ending of the year. And we'll wish all a wonderful time during Christmas and New Year, and hope to see you again in the new year. I think the Director, I would like to suggest that Addis, can you get the PowerPoint on the screen? Thank you very much. Let's move on to the next slide. Yes, I'd like to start with the good news of the year from Rwanda. We are now outbreak in Rwanda. The Minister of Health has planned the national celebration tomorrow, Friday, at 10 a.m. at the Kigali Convention Center. I think we have to say that this success is really the result of the swift and coordinated effort that was led by the Minister of Health in collaboration with Africa CDC, WHO, and all the key partners. And there are some measures that we can really count on that have contributed to this success, which include the leadership commitment with a prompt and transparent communication from the Minister of Health. We had the minister joining our weekly briefing just to give as much information as possible on the situation. We've also seen the enhancement of the national surveillance systems that allowed the early case detection, the intensified contact tracing, and the early case isolation. We also saw very high level of laboratory testing of all suspected cases with a very short result turnaround. We saw also the expansion and the upgrading of treatment facilities that were really of very high standard toward the global standard. And finally, there was really an intensification of the awareness campaign to ensure that the public have got the necessary information on how to prevent the infection. Now, very, very important also to notice that because of all those interventions, especially the high standard of care in the treatment facilities, Rwanda achieved some of the lowest case fatality rate, which is estimated at 22.7%. That is much lower than what is registered in the previous outbreaks, where mortality, the case fatality rate was around 50%, with a range between 24 and 88%. And Rwanda being at 22 is really at the lowest end of that range. Next.
Dr. Ngashi, just...
Yeah, the second...
If you can hear me,
yes, Director?
Just before you go on, maybe you can switch off your video because I think the audio is breaking up quite a bit. Thank you.
Okay. Now, I think the second situation I also wanted to brief is the febrile illness in the DRC, this disease X, which has been observed in the health zones of Panzi in Kwango district. Now, 592 cases that have been registered, 37 deaths, giving a fatality rate of 6.2%. But those are deaths that have been registered in the healthcare facilities. But we also have another 44 deaths reported at community level that are under investigation right now. Now, compared with the previous week, I think there have been 65 additional cases that were registered and 5 additional deaths. Next. Now, those 65 additional cases were all investigated. I think they came from 2 areas in particular, the area of Chakalapanzi and also Kanzangi. The testing rate was at 78%. I think the linear list was updated. But very important is also that there have been an active search of cases and deaths in the community, and 20 households have been visited, of which 3 deaths have been reported. Now, on the laboratory side, the 78% testing rate translating to 51 cases that were sampled, 181 samples that were collected and sent to the laboratory. Now, the finding so far is that on the qPCR malaria testing, multiplex testing that was conducted of 29 samples, 25 of them tested positive for malaria. That is a positivity rate of 86%. In addition to that, there was also the rapid diagnostic test of malaria that was conducted in 88 patients. 55% of them tested malaria positive. Just to say that, that is why the diagnosis is leaning more toward malaria based on the laboratory diagnosis. Next. Now, there's also some new development that there's an adult male patient that has died of an hemorrhagic fever syndrome. The sample has been taken and sent to Kinshasa for laboratory testing. Now, based on those 2, I think the 2 working hypotheses currently are that it might be that it's a case of we are dealing with an outbreak of severe malaria on a background of malnutrition and viral infection, or now looking at the adult male patient with that hemorrhagic fever syndrome, that it could be a viral infection that is happening on a background of malaria and malnutrition. I think those are the 2 hypotheses that are being verified. Next. Now, coming back to Mpox, the result on data of AP week 49 showed that, first of all, we just concluded yesterday the country and continental interaction review. That was conducted in 2 phases. Phase 1 was at country level in the category 1 countries, where the countries had the opportunity to sit with partners at their level and then try to see what are some of the successes, the failures, the best practices, and the gaps that remain, and also reflect on the priority actions moving forward. And then yesterday, over the last 3 days, from Monday to Wednesday, we gathered with all the partners in Addis to also have now a broader view of the continental response. The second important information to say that there's 1 member state that has moved from controlled stage to active transmission, that is Guinea, now bringing the total number of countries in active transmission phase to 15. And out of the 20 countries that have reported cases, it means that there are 5 member states that have remained in controlled stage. That's Gabon, South Africa, Morocco, Zambia, and Zimbabwe. Now, on the number of cases reported during the same week, we are now at 3,095 new cases that were died. That is in comparison of 3,545 the week before. We registered the same week 553 new confirmed cases. That's in comparison of 467 the previous week, and 31 new deaths compared with 37 in the previous week. Now, among the total confirmed cases, children below the age of 15 represent about 34%, and females now represent 54%. Just to show that, as the outbreak is progressing, we have seen that shift, the reduction on the number of children that are infected and the increase on the number of females that are infected. But compared with the total number of confirmed cases during the entire year of 2023, it's about 789% increase, which shows that really it is an outbreak of much greater magnitude. Next. Now, on the continental intra-action review that I spoke about, that was conducted between the 16th and 18th of December in Addis Ababa. Countries presented the outcome of their national reviews, and the continental IMST brought all that together to put together into one single review of the continental situation to make recommendations. I think just to say that those collaborative analysis that helps us to identify the best practices, the gaps, the lessons, and also define the priority actions for the remaining 2 months of January and February to the end of the continental plan. We had the member states that participated to this process, both the country level and the continental level process. That's about 9 countries: Burundi, Central African Republic, Cote d'Ivoire, DRC, Kenya, Liberia, Uganda, Nigeria, and South Africa. And also 7 key partners, I think, that were involved in the entire process. I think that's Africa CDC, Gavi, IFRC, the UK Public Health Rapid Support Team, the US CDC, UNICEF, WHO, and the MSF. I think we also participated online. Next. Now, the main outcome of this intra-action review, I think we identified 8 priorities that are urgently needed to accelerate the response. The first priority is to intensify the resource mobilization. Out of the 1.3 billion, I think that was pledged, only about 15% mobilized so far. I think that's why we really need to intensify to get more resources to support the acceleration of the response. The second priority area is to intensify the country support, especially targeting the hardest hit countries. We had the first phase really to define the strategies and provide the guidelines really for this response. Now, this second phase, we'll see really the intensified support to the countries. The third priority area is on data management systems. We are now working on really developing a system that can improve the quality of data, the timeliness of reporting, but most importantly also is to link the surveillance to the laboratory, to the treatment centers, and to the vaccination, so that we have one single system that can really contain all the information needed to track the progression of the outbreak. The fourth priority is the vaccination. As you have seen, we have 9 countries that received the allocation and the 3 that are now vaccinating. I think it is time to accelerate and work with the remaining 6 countries to also ensure that they also move into the implementation phase. The fifth priority is to really intensify the integrated approach to the response, to make sure that the pillars are all integrated and can work together to optimize the impact of them on the response, targeting in priority 2 areas. First of all is the community response, that we are developing a community package that can, using community health workers, with services that include surveillance, community-based surveillance, that include community engagement and risk communication, and also infection prevention and control. And we like to do the same also on the data management system, moving away from the vertical system that have been used by different pillars, one for surveillance, one for vaccination, one for laboratory, to integrate all that into one single platform that can be used to save the entirety of the response. The sixth priority is also to look at the co-infections, as we have seen that in some countries we have test positivity rate to Mpox that are below 50%. And what then do we do with the negative to Mpox but positive to other diseases? As you know that diseases such as chickenpox and measles have also been identified to be prevalent in some of these communities. We need a response that can also address those diseases. The seventh priority is really to document some of the best practices and share them between countries using different strategies, whether it is through webinars or study tours that can really allow countries to learn from each other. And finally, we like also to intensify the search human resource capacity in those countries so you can harmonize the terms of reference and also track the performance of those different human resources that are deployed to support the response. I think those are the eight urgent priorities that were identified through this intra-action review. That will be the focus of the IMST as we move into the second phase of the implementation of the continental plan. Next. Now, the situation in the DRC on week 49, the number of the total 3,109 cases, of which 10,737 have been confirmed, and 1,251 deaths, with a case fatality rate on the notified cases of 2.4%. But for the week of AP week 49, we had 2,632 new cases notified. That is against 2,549 the previous week. We had 156 confirmed cases against 180 the previous week, and 29 new deaths against 33 in the previous week, with a case fatality on week 49 of 1.1%. Now, among confirmed cases, males now make 46.7% of all confirmed cases, and children have reached now 49.3%. And again, on the clades that are circulating in DRC, we have both 1A on the west, 1B on the east, and then both of them co-circulating in some provinces like Kinshasa. Now, on the sequencing, I think DRC is doing very well on the sequencing of confirmed cases. I think our target was 5%, but DRC is doing the sequencing at they're already at 7%, which explains why there's a very good understanding of the type of clades that are circulating in different provinces. Next. Now, on the vaccination in the DRC, as of 19 December, the update is that the initial provinces have started now the administration of the second dose since November 28. And so far, we have about 11,000 people that have been vaccinated in 3 provinces of Chopo, Sankuru, and Sud Kivu. And in addition to that, I think some of the prisons that are the reported cases are also being covered with vaccination. More than 1,500 persons have been vaccinated in 2 prisons in Sudubangi and Nord Kivu. Vaccination continues in Kinshasa with a focus on the high transmission areas, which are Pakajuma and the Kokolo areas. Next. Now, the second good news also about DRC is that finally, we have some confirmation on the arrival of the LC16 vaccine the Japanese government has confirmed that 50,000 doses will be arriving in Kinshasa this week, and then the remaining of the 3 million doses should also be deployed from February 2025, just to have this period really for learning. And to facilitate that, the Ministry of Health hosted the Japanese expert, into a workshop that started on the 16th, that Monday, and it is ending today, on the 19th, that looked at really the preparation for the introduction, looking at pharmacovigilance, looking at the adaptation to the local context, looking at the monitoring of adverse event. In addition to that, the workshop is also looking at capacity building and training, understanding that this vaccine is going to be introduced for the first time, and it has also its own uniqueness. For example, the type of needles that are being used, for which capacity building and training are important components of this preparation, and also the preparation of the vaccine rollout plans. I think that also being discussed, looking at all aspects of that on the operational side of it, but also on the cold chain for the storage of vaccines at different levels. Next. In Nigeria, I think Nigeria has also made some good progress on the vaccination with the initial 9,000 doses that they received from the US. As you can remember, they received the 10,000 and donated 1,000 to Rwanda and kept 9,000. Of that, they have vaccinated 4,278 people. The acceptance has been quite good in the communities and also among the health care workers. Now, the coverage of the target population, the 4,000 that we are talking about, all have received the first dose and now moving into the second dose, which is now part of the planning. But because it was also the conditionality, Nigeria is also expecting to receive the second allocation of the 11,000 vaccines, I think, with the shipment that is expected to arrive tomorrow, now for them to move then into the second phase. Yeah, I think that is it. That is the essence of what we wanted to present today. Director, back to you.
Thank you, Dr. Ngashi. Let's take the questions from the floor. Helen from START, you have the floor. Over to you.
Thank you, Margaret. My question is about the situation in Pansy. I heard the suggestion that there may be somebody there who has viral hemorrhagic fever-like conditions, but in the main, it sounds like you're finding, or excuse me, the health authorities in DRC are finding malaria. So I'm kind of puzzled as to why we're still talking about disease X and talking about this as if it's not something that is known. It seems like there is, a bad season of malaria among people who are malnourished. No? Thank you.
Thank you. Let's take the next one before Dr. Ngashi comes in. Janice from Bloomberg, you have the floor. Janice, can you hear us?
Yes, I can hear you. Can you hear me?
Yes,
Great.
we can hear you.
Thank you. I believe that the food scarcity in Pansy has deteriorated significantly in the last 4 months. And I was just wondering if someone would comment as to what has caused that. I believe that there is militia in the area, and obviously, as we've heard in previous briefings, the roads are very poor, and there's been a lot of rain. And I was just wondering what would have made the food scarcity issue and malnutrition worse. Which would have potentially led to weakened immune systems, etc.
Thank you. Dr. Ngashi, over to you.
Yes, thank you very much for those very good questions from Helen and Janice on pansy. I think on Helen's question about the diagnosis, for now, as I said, the working diagnosis now is really malaria on a background of malnutrition. I think that is the working diagnosis. But because of the fact that the testing of samples is still ongoing, there was a team that was deployed there to do the investigation, and we're still waiting to look at the outcome of that investigation. And in addition to that, we are now seeing another picture of a viral hemorrhagic disease. I think that's the reason why they are still talking about a working hypothesis to say that the most probable is malaria, but the second could be the viral disease on a background of malaria, given the fact that it is the rainy season, it is a malaria endemic areas, which means that regardless, this is really the time that you also expect malaria to be in that area. And then the fact that malnutrition has really increased, I think that's a Janice question. There's a lot of, first of all, it is the heavy rains is one of the things, and the infrastructure has deteriorated so badly that really access to that area is a problem. Now, when there's an access problem, it also limits the capacity of those isolated communities to also get their product out to sell, to get some revenue that can allow them to get some food product for food security. It is the combination of that then can partly explain what we see now. But as I say, that we are all waiting to see the result of the investigation. We get some more solid understanding of really what has played into that community to see what we are seeing right now.
Thank you. Let's take the next question. Stephanie Nolan from New York Times, you have the floor.
Thanks very much, Meg. I actually have 3 questions, and they all pertain to Mpox vaccination in the DRC. The first is that my understanding is that specifically on the subject of vaccination in Kinshasa, my understanding is that Africa CDC is partnering to lead that there with the DRC Ministry of Health. And I'm wondering if you could say more about how often vaccination is happening in Kinshasa. I spoke with people in charge of the Mpox Center in Pakajuma yesterday, and they said there had been only 2 days of vaccination so far. They couldn't tell me when the next would be. And so I'm wondering if vaccination is going to be regular and how often and how many people you expect to be vaccinating there and who will be doing it. My second question is that the current numbers show 56,000 people vaccinated in DRC in, I guess, a little bit more than 2 months. And I'm wondering if at Africa CDC you're satisfied with that speed. Do you anticipate that it will accelerate at all? And what would need to happen for that to go faster? And third, my understanding is that a further 300,000 doses of the genus vaccine that were pledged by the US government are ready to go, have been for some time. But the holdup is waiting for DRC or Gavi to agree to handle the import costs for those. And I'm wondering, do you have any sense of when that's going to be resolved, given that presumably there is some urgency to move those vaccines before the change in the US administration? Thank you.
Thank you. Over to you, Dr. Ngashi.
Yeah, thank you very much, Stephanie, for those important questions. First of all, I think on the regularity of vaccines, of vaccination, I think the vaccination plan was really to vaccinate regularly for at least 10 days until they complete the target population. And if for some reasons there are delays and the population is still coming up for vaccination, they extend that period. I think just to say that we need to investigate what can explain the 2 days, whether they have stopped, because that's also the time that we're involved in the Intra-action review in Addis. Now, on the 56,000, if Africa CDC is satisfied, not at all. Because you remember that we have already deployed 382,000 doses of Mpox vaccine to the DRC. And with the allocation that was conducted DRC was given another 700,000 doses. And the condition now for us to continue deploying is the absorption of the initial allocation of 386. Now, if they are still at 556,000, you see that that is very far, really, from reaching the target that they had set for themselves at the beginning. Now, what we are doing, I think, during this intra-action review, in DRC, we also wanted the country itself, with all the partners, to review that performance of vaccination in DRC to identify some of the reasons why the performance is not as fast as it was expected to be. I say there is some of the real issues that it is played mainly on the demotivation of the response teams and the vaccinators. I think that is one of the reasons that was raised. And both WHO and Africa CDC committed to the government that we would like them to sit, because all of us have made allocations to provide some financial motivation, but that to be conditional to performance. I think just to say that no, this intra-action review was a good opportunity to also look at the performance, and then so we can then agree together on how we can accelerate the vaccination in the DRC. Now, about the 300,000 doses, I think that's something that we are aware of, that we had planned that most likely we're looking at the beginning of the year for us to bring the additional 300 doses from the US, given the fact that we see it extremely difficult for them now to absorb the remaining 330,000 doses of vaccines during the remaining 2 weeks of December before we start now bringing more vaccines. I think that is our rough estimate right now, that we really want to start from now and January to push on the acceleration to absorb what they have already received. And we are hoping that it will be somewhere there toward end of January, beginning of February, then we can then start calling for additional doses to come into the DRC. Because these are expensive vaccines, we don't want them to expire in the DRC. It is also a kind of a push. We are putting pressure on government to say, you cannot just be asking for vaccines if you are not able to absorb them. And the last meeting, we got very good feedback that the minister himself was also concerned about this performance, and really putting pressure on his teams. And if we come together with WHO and provide also the support and the motivation, we are hoping for better results moving forward. Over to you, Director.
Thank you, Dr. Ngashi. Back to the floor for more questions. Gabriel Emmanuel from NPR, you have the floor.
Hi, thank you very much. I had two different questions. The first one, I am curious about the situation in Panzi, and my understanding, I spoke to one scientist who said many people actually have the malaria parasite in their blood because it's just so common in the area, such that a positive malaria test might not be what's actually causing them to get sick. So I was wondering if there have been other diseases that have been eliminated from the differential of what could be causing this outbreak. I understand there's a lot unknown, but whether there are diseases that have been kind of crossed off. And then also when we look to Rwanda and the celebration at the end of the Marburg outbreak, I wanted to see if you could speak a little bit about what ongoing monitoring will be happening of the survivors, given the low mortality rate. There are more survivors than normal. What kind of processes are in place to monitor and support them? Thank you.
Thank you. Let's take the next one before Dr. Ngashi comes in. Makochi of Okafor from BBC, you have the floor.
Okay, hi. So I just wanted to be sure about the disease in the DRC. I know that current investigation is still going on. Do we have an idea of how long it might take before we get like a clear answer on what this new addition, the viral addition that we're looking at now would be? And also, are there diseases that are being like looked at? Is it like Lassa fever? Is it like Marburg? What is the suggestion? Is there anything we can look at just in line with this new discovery? Thank you.
Thank you. Over to you, Dr. Ngashi. Dr. Ngashi? Dr. Ngashi, can you hear me?
Gabriel and Makushi for those questions. Can you hear me also?
Yes, we can hear you.
Hello, can you hear me?
We can hear you. We had lost you for a minute. Yeah.
Oh, sorry. I think that's the internet connection. Yeah, I was thanking Gabriele for the question and saying that the point she made on malaria, that is the reason why the second hypothesis, works on a viral disease which is happening on the background of malaria, because malaria is endemic in the area and also of malnutrition. And that's also where even this discovery of this new case with an hemorrhagic syndrome might also be pointing toward that hypothesis, because malaria is not just straightforward convincing as a diagnosis, given that this is an endemic area. For malaria, they are also exploring other things. If you remember, when I was also presenting, I spoke about the qPCR multiplex that is going, and because of this case of hemorrhagic fever, they're also testing for Lassa, for Marburg, for Ebola, just to see exactly if it might be one of those diseases, those viruses. I think that is quite into play here. Now, at the time it takes, I think there's a lot of pressure also from the ministry and from the diagnosis is, and all of us, Africa CDC, we are getting regular updates on our daily updates with the laboratory exactly on the diagnosis. Even this morning, the DG shared with us the update that he received from the laboratory. We are hoping that in the next 1 week, we should be able to get at least the initial result on those samples that have already been brought to the national laboratory, Marburg, and the follow-up of the survivors. I think this is one key point. I think that was taken, learning from the experience of Ebola, that there is a system for the follow-up of the survivors, and even a research. I think that has been identified. I would like to invite here Dr. Musoka, who is leading our research pillar, if he can make a comment on the effort really on the monitoring of the Marburg survivors in Rwanda. Dr. Musoka.
Thank you so much, Dr. Ngashi. So indeed, there have been 2 strains of follow-up on the Ebola, so on the Marburg survival. One of them is the basic services for survivors. We do know that after leaving the treatment unit, there's always some challenges. And then we develop a protocol, a joint protocol with the Rwandan Biomedical Institute, the University of Kinshasa, the University of Rwanda, and WHO, to be able to follow this survival for 2 years, to check on any clinical complications. That's one. The second objective, as we saw with Ebola survival, the potential for resurgence. And so the protocol is approved, and we're in the process of launching the protocol to be able to follow them. As we saw in West Africa, that after the major outbreak, there were multiple of sexual transmission by resurgence. So that protocol is approved, and the processes are in place to begin the study. But meanwhile, the survival service program is ongoing. The Marburg survival program is ongoing in Rwanda. Thank you.
Thank you. Let's take the next question from the floor. Kerry from Health Policy Watch, you have the floor.
Thank you, Margaret. I also want to drill down a little bit more into the Panzi cases. What made people sound the alarm there, given that it looks like the symptoms are very similar to malaria? Was it unusual deaths, or is there something slightly different in the case manifestation? That is question one. And the second question, my usual question, when is Burundi going to roll out the Mpox vaccinations? Thank you.
Thank you. Let's take the next one before Dr. Ngashi comes in. Paul from the Lancet, you have the floor.
Yes, thank you very much. So my question has to do with the Africa CDC's preparation for a possible, for a Trump presidency in the US. We've had a lot of Africa CDC's programs heavily rely on the support from the US. How is this expected to play out, and what are the modalities in place in order to cater for any potential reduction in the US funding to support public health initiatives in Africa? Thank you very much.
Thank you. Over to you, Dr. Ngashi. Dr. Ngashi, you can hear us?
Thank you very much. Can you hear me?
Yes,
I hear you. Can you hear me?
I can hear you now.
All right. Yeah, thank you very much. To Kerry's question about what was the trigger was the high case fatality rate. If you look at the numbers that we have, mortality at health facility level, it's already 6.2% case fatality rate. And there were also other community-based deaths, even more than the ones that were reported at facility level that are still being investigated. That was the trigger, the high case fatality rate. Now, in Burundi will be conducting its intra-action review at the beginning of January, but they also participated in the intra-action review in Addis, and the case of vaccination was raised. I think it was discussed. They were very interested to learn from the experience of DRC. They really wanted the DRC to share their initial experience with them, which the DRC did during the meeting, and they would like to take that experience and then integrate it also during the inter-action review to then make a recommendation. And it was also agreed that the IMST, the Continental IMST, will be part of the action review to be able to guide them, in really setting up priorities, including also the decision on Mpox vaccination. Now, on Paul's question about what might happen with the new government, I think I have to say that, as Africa CDC, we work with any government that is there. I think that is the reality, that we always believe in the continuity of government. And that, well, for now, we don't really receive much funding from the US government, if I can say so, because we are in discussion with the US agencies we've already defined the priorities of our collaboration in different areas with the different organs within the US government. We also have been discussing on budget, but so far we are receiving the technical support of the US with some of the technical experts from US CDC based at Africa CDC, but we are not yet heavy on receiving funding from the US government. I think for us, we see this as an opportunity for the Africa CDC to engage with the new government to see how we can then materialize the discussion that we started with the current government into the concrete, then intensified financial support of the US government to Africa CDC. Over to you, Director.
Thank you. Let's take the next one. Priyanka, you have the floor.
I was wondering, when did the adult male in Pansy that you mentioned die of the signs of hemorrhagic fever? And a follow-up is that, are there any sort of investigations underway to assess the close contacts of this person? And in your understanding, are there any links to some of the cases that we're talking about?
Thank you. Let's take the next one. John Songo from Radio Pan-Afrique, you have the floor. John, can you hear us? All right, let's take the next question. This one is from the chat box. What kind of lessons can the rest of
Allô, Marguerite, vous m'écoutez?
Yes, go ahead.
Marguerite, vous m'écoutez, s'il vous plaît?
Oui, go ahead.
D'accord. Ma première question parle de... Je voudrais savoir ce que le CDC Afrique apporte comme soutien au système sanitaire de la RDC, vu que ces derniers temps, il semble un peu fragile, notamment avec la multiplicité des épidémies, des maladies non encore connues, le cas des...
of outbreaks. We are now seeing what is happening in Panzi and Bukwango. My second question. I'm asking this question to Dr. Ngashi on behalf of the Ministry of Health of Burundi. Has CDC realized a positive reaction in the assistance in the contribution of the PCR in data collection, my third collection? I would like Dr. Ngashi to make a distinction between the data of Marburg fever, which is celebrating the end of Marburg tomorrow. I would like to know if this data are having a link with Mpox in DRC. Is this having a link with the situation of Mpox in Burundi? Thank you. Over. We're sorry the sound was not very good. We did our best to listen.
Director, John, si vous pouvez répéter encore vos questions, we didn't get the question.
Kindly repeat your question because we did not get you well. Kindly repeat the three questions, please.
La question était quel est l'apport du CDC Afrique?
What's the contribution of CDC Africa to support the health system in DRC, which is increasingly vulnerable given the multiple outbreaks that are happening, such as Mpox and the new outbreak in Lukwango and Panzi? The second question, I want Dr. Kashi of Burundi should have quickly summarized to us the data that are actually showing a difference between the evolution of Mpox in Burundi and Kinshasa and that of Marburg virus in Rwanda. The third question, what is the contribution of the PCR test that was validated recently by CDC that was manufactured in Morocco in the health system, especially in terms of data harvesting of the continent? Thank you. And over.
Dr. Ngashi?
We're not hearing Dr. Ngashi.
Dr. Ngashi, can you hear us?
Okay. Yeah, thank you very much. Do you hear me now?
Yes, we can hear you.
Okay. Now, if I start with Priyanka's question about the case of hemorrhagic fever, we received the message that was forwarded to us this morning, which was say that an adult male has just died of an hemorrhagic fever syndrome. That since it came this morning, it means that it is something that might have just happened over the last 2 to 3 days. But what we hear also is that the sample has already been collected and it has been sent to Kinshasa. That it is on its way to Kinshasa. It's a very recent case. Now, on John, la première question de John, c'est de voir quelle est
The
la
first question that was raised by John was to know what Africa CDC supports in the strengthening of the DRC health system, given the many outbreaks that the country is facing. I just want to say that we are assisting the country in strengthening its health systems, especially in the area of surveillance, which is very weak, in the strengthening of the laboratory systems, in the strengthening
de la capacité au niveau de l'Institut, donc au niveau national de l'Institut national de santé publique,
the National Health Institute, especially at the level of the EOC and the coordination teams. So these are the areas in which the CDC, Africa CDC, is supporting DRC. We have had a discussion with the ministry in which we have said that given the advent of these many outbreaks, we are now having an opportunity to seize the presence of so many partners in the country to actually build the resilience capacity of this health system. One of the things we're doing in the DRC now is that we're trying to decentralize the laboratory system in order to bring the laboratory capacity closer to the peripheral health systems. So each district will have a gen expert machine for diagnosis at the decentralized level. So each province is receiving qPCR machines in order to have a greater technical capacity in the area of screening. And at the national level, we are also providing support in the area of sequencing, not only to the DRC. You know that the Africa CDC distributed sequencing equipment to about 44 countries throughout the continent. With regard to surveillance, we're also working with the government in order to digitalize the surveillance system in order to fast-track the transmission of information. We're also working with the government to introduce some elements in the community that can carry out surveillance in their villages and localities, and that can also play a role in risk communication and community engagement in order to facilitate the education of communities to better control infections. So these are the priority areas in which the CDC is collaborating with the government of DRC. And as you know, we are also supporting the National Health Institute to strengthen in capacity building in the maintenance of equipment, so that we are presently donating many equipment to the tune of about $500,000 to strengthen the equipment capacity of the country. So these are the areas in which we are working very closely, not only us, but we hope that together with other partners, we'll be able to set up a very resilient system that will enable us to prevent these outbreaks, but also to diagnose them on time and ensure an immediate response. With regard to the data you were talking about for Burundi, Rwanda, and DRC, in the DRC, we can see that the outbreak, the numbers are still rising. Surveillance is still weak. IPC is now, that IPC is being increased. Vaccination has been introduced, but the coverage is still weak. But we hope that in the second phase, when vaccination coverage will be intensified, that IPC systems will also increase, and that thanks to the decentralization of the laboratory system, will be able to better control the outbreak. This is the same situation in Burundi. Given progress, good progress in the care provision, but given that the number of cases is still increasing, we have understood that surveillance should be strengthened as well as prevention. In Rwanda, the progress is very appreciated. It's about 42 days that we have not recorded any case of Marburg. So that's the end of the incubation period. That's why we're having this celebration tomorrow. That's a good result. But in two countries, in one country, we've had a lot of results, but there are two countries that have had appropriate results. But with regard to the introduction of the qPCR equipment, the performance was assessed and is good, with a rate of sensitivity of about 100%. That's why this equipment was recommended as one of the first equipment produced on the continent that could be used for us to actually step up our local equipment production. So in a nutshell, this is the answer I could share with you with regard to this question. Thank you. I'm over.
Thank you, Dr. Ngashi. Let's take the last question from the floor. John Agaba, you have the floor. John, can you hear us? John, can you hear us?
Hello?
Yes, we can hear you. Go ahead.
Thanks, Margaret. I have two questions on the Marburg outbreak in Rwanda. What lessons can the rest of Africa learn from Rwanda's response? And can we attribute this very low 23 case fatality rate to the investigation that's used? And secondly, how is the Africa CDC helping to improve surveillance and maybe health work training and vaccine development to detect and stop these filoviruses that are predominantly in remote Africa?
Thank you. Dr. Ngashi?
Yeah, thank you very much, Director. And thanks for the question. I think some of the main lessons that we can draw from the Rwanda experience with the rapid control of Marburg is number one is the leadership. You saw that during weekly teleconferences that the minister was really on top of things. Was on top of things. You know, they on every key player that was there, employed the team right from the start. It was at the request of the minister. We had more than 10 experts, you know, recruited very fast in a very short period because there was pressure from the leadership. You know, that is the kind of leadership that really has played a major role in the results that we've seen. Secondly, it's also the strong surveillance system. You'll see that Rwanda very quickly, we saw that most of the new cases that were reported were coming out of the contact list. It tells you that you have a surveillance system that works, that every time that they identify a case that was confirmed, they quickly listed all the contact and established the 21 monitoring system that tracked them and picked those that developed the system. I think that is one of the positive things. And then thirdly, it's the laboratory system that is really that really worked. Both the capacity and the sample transportation, they had 100% testing rate. I think there was no sample.
Dr. Ngashi, we lost you. Dr. Ngashi?
And the turnaround time of result was also very short. And finally, it is the standard of care. I think that explains the low case fatality rate that was saying. Can you hear me now, Margaret?
Yes, we can hear you.
Director.
Yes.
Okay. Now, I don't know how far you heard me. I spoke about leadership. I spoke about strong surveillance. I spoke about high lab capacity. I also spoke about the high standard of care with really an earmarked treatment center where all the cases were taken and they had a holistic approach to care. I think those are some of the lessons that we draw from there. And then as we think about building resilience, I think these are some of the things that Africa CDC will really emphasize, is really drawing from the lesson of Rwanda. How do we build the similar, strong surveillance system in other countries? On the lab, I can say that on the lab, we are quite advanced. We are hoping that lab is one area that Africa CDC is going to move very fast. But there are also other areas like these infectious disease treatment facilities that need to be also constructed in the country that are permanent, that once in the case of outbreak like this, patient can be taken. Now, the second question was on what was the second question? Director, do you hear me?
Yes, we can hear you.
Yes, I think John had the second question. There were two questions, right?
Yes. John, can you hear us?
Yes, thank you, Doctor. I wanted to know if maybe this low case fatality rate could be a result of this investigation of vaccine that was used. And you touched on it, on how Africa CDC is helping to improve surveillance, vaccine development to, stop, detect and stop these viruses that are common in Africa.
Thank you. Dr. Ngashi?
Yes, yes. The low case fatality rate, I think, benefit from two things. One, for those that are vaccinated, that we've seen most of these vaccines, they help with the prevention, and where people that are vaccinated still catch the diseases, they help with the disease progression. So they reduce the severity of the disease, and they reduce the case fatality rate. I think that's how vaccines do work. At the same time, if you are also providing high quality care, the combination of both will really result in very low case fatality rate. I think that's the reason why, as one of the strategies of Africa CDC linked to the local manufacturing, is to really make sure that we build enough capacity on the continent to also produce the medical countermeasures, including the vaccines, but also treatment, so that we can improve both the prevention, the effect of vaccination, and at the same time also the case management of these diseases when they do occur.
Thank you, Dr. Ngashi. And with that, we've come to the end of our last briefing for 2024. I will now hand it over to Dr. Ngashi for his closing remarks. Dr. Ngashi, over to you.
Thank you very much, Director. Let me first, on behalf of the Director General and also the Continental Instant Management Support Team that is co-led by Africa CDC and the WHO, thank all the participants for joining us today. We recognize that this support is very much appreciated, because some of these questions also guide us, in the actions that we take at this level. They help us even also identify some of the blind spots that we go back and just refine the response. It is very much appreciated. We really appreciated you joining us and really asking these very important questions. Today is our last press conference of the year. As you all know, the end of the year is usually characterized by high population movement and a lot of gathering, also for celebrations. And this is happening in different places and in countries that are affected. Among these 20 countries that we are talking about, and especially the 15 countries that are in a high transmission mode, we like just to remind everyone to celebrate safely. Do not forget, all the measures to prevent Mpox. Really keep the hygienic practices very high, as simple as hand washing. Be a bit more alert around you. If you see anyone that is presenting symptoms, or yourself you present symptoms, that's really encouraged to rush very fast into the health facility to isolate the person and also benefit from the best of care. And most importantly, just stay safe and have a happy end of the year, and hoping to see all of you in the new year alive and in good health. Thank you very much.
Recording stop.